Let me share a story with you. I'll refer to her as Margaret. She was 68 years old, mentally razor sharp, tackled the crossword puzzle every single morning, and could recall every family birthday without ever glancing at a calendar. Her daughter used to joke that she was the living search engine of their household. Then, roughly a year and a half after her physician added a new drug to her daily regimen, her daughter reached out to me in tears. Margaret couldn't retain what she'd had for breakfast. She was getting disoriented driving back from the same supermarket she'd been going to every week for 2 decades. She'd asked the same question 3 times within a single conversation. Her neurologist was leaning toward an early Alzheimer's diagnosis. The family was crushed. But here's what no one ever told them, and this is what I need you to truly take in right now. Margaret's cognitive decline wasn't Alzheimer's at all. It was sitting right there in her medicine cabinet. When we carefully went through her medications and made deliberate adjustments alongside her physician, Margaret began returning to herself. Within 4 months, she was back at her crossword puzzle. This isn't some miracle story, this is preventable medicine. And today, I'm going to walk you through the 9 most common medications that could be quietly and invisibly eroding your memory, ranked from the most frequently overlooked all the way up to the most dangerous combination that most doctors never bother to warn you about. I'm Dr. Eric Sinat, and this video might just be one of the most valuable 20 minutes you invest this year. One quick note before we get started. Stay with me through to number 1 because number 1 isn't a single drug. It's a hidden pattern affecting millions of older adults right now, and almost no one is discussing it. Let's get into it. Before we go through this list, I want to make one thing crystal clear. I am not advising you to discontinue your medications. Please do not do that without first consulting your physician. What I am telling you is that you have every right to ask questions, to understand what you're putting into your body, and to stand up for your brain health. Knowledge isn't dangerous, silence is. Also, drop a comment below right now. Tell me, are you over 60? What medications are you currently on? I personally go through the comments and I genuinely want to understand what you're facing. Your experience may end up helping someone else watching this very video today. Number 9, diphenhydramine. Let me ask you something. How many of you have a small bottle of Benadryl sitting on your nightstand right now? I'd guess quite a few, and I completely understand why. It's inexpensive. It's available without a prescription. It says sleep aid right on the label. What could possibly be harmful about that? Here's what that little pill is actually doing inside a brain that's over 60. Diphenhydramine belongs to a drug class called anticholinergics, and that term is going to come up repeatedly in this video, so keep it in mind. Anticholinergics function by blocking a neurotransmitter called acetylcholine, which serves as the brain's primary chemical messenger for forming memories, sustaining focus, and staying cognitively alert. When you're younger, your brain produces acetylcholine in abundance. Once you're past 60, your baseline is already reduced. Block even more of it with a nightly Benadryl, and the impact becomes significant. A landmark study published in the Journal of the American Geriatric Society found that older adults who used diphenhydramine on a regular basis faced a substantially elevated risk of cognitive decline, with neuroimaging revealing measurable shrinkage in the brain regions responsible for memory. The sneaky part? It hides inside dozens of products you'd never even associate with antihistamines. Any product labeled PM, nighttime relief, or sleep formula almost certainly contains it. What to do instead? For allergies, ask your doctor about second-generation antihistamines like loratadine, Claritin, or cetirizine, Zyrtec. These don't penetrate the blood-brain barrier the same way. For sleep, we'll get to safer alternatives later in this video. Number 8. Proton pump inhibitors, PPIs. Raise your hand if you've ever been told you need to take an acid reflux pill every morning and you've been doing it for years without anyone ever suggesting you consider stopping. This is one of the most overprescribed medication categories on the planet, and the real problem isn't just that people take them, it's that they take them indefinitely, when most were originally designed for only 8 to 12 weeks of use. Proton pump inhibitors reduce stomach acid. Simple enough, right? Except your stomach acid also plays a critical role. It extracts and absorbs vitamin B12 from the food you eat. And B12 is not optional when it comes to brain health. It is absolutely essential. B12 deficiency is clinically associated with memory impairment, depression, nerve damage, and a pattern of cognitive deterioration that so closely resembles early Alzheimer's that the two are sometimes confused, even by seasoned physicians. A 2016 study published in JAMA Neurology looked at more than 73,000 adults aged 75 and older and found that long-term PPI users had a 44% higher risk of developing dementia compared to those who didn't use them. But there's another layer to this. Research has also indicated that PPIs may speed up the buildup of amyloid beta plaques, the toxic protein deposits that are one of the hallmarks of Alzheimer's disease. This goes beyond a simple B12 deficiency. We could be looking at a direct molecular pathway toward neurodegeneration. What to do? Speak with your doctor about gradually tapering off PPIs using H2 blockers like famotidine, Pepcid as a transitional bridge. Dietary adjustments, smaller portions, avoiding late-night meals, and slightly elevating the head of your bed can significantly reduce reflux on their own. And if long-term PPI use is genuinely medically necessary for you, ensure your B12 and magnesium levels are monitored regularly. If you're still with me and finding this useful, type the number 8 in the comments right now. It tells me you're engaged in getting something out of this. Number 7, bladder control medications. This one genuinely frustrates me, not because of the medication itself, but because of how rarely patients are given the full picture. Overactive bladder is a real condition. It's embarrassing. It disrupts sleep. It significantly affects quality of life. And when a doctor writes you a prescription for oxybutynin and tells you it will help, of course you take it. What almost nobody explains is this. Oxybutynin is one of the most potent anticholinergic medications in routine clinical use. It doesn't just act on your bladder. It crosses the blood-brain barrier with remarkable ease and directly disrupts the same acetylcholine systems that are responsible for your memory and your ability to learn. Studies have shown that the hippocampus, the brain's memory center, actually undergoes measurable volume reduction in long-term anticholinergic users. We're talking about a real, physical, structural change in brain tissue, not just fuzzy thinking. A comprehensive 2019 study in the British Medical Journal found that seniors using strong anticholinergic medications like oxybutynin for more than a year had a 49% higher risk of receiving a dementia diagnosis, nearly 1 in 2. Here's what makes this particularly heartbreaking. The early cognitive symptoms, forgetting appointments, misplacing everyday objects, losing words mid-sentence, are almost universally written off as normal aging. The medication never comes under scrutiny. The good news is that newer bladder medications like mirabegron, Myrbetriq, operate through an entirely different mechanism and carry dramatically lower cognitive risk. If you're currently on oxybutynin and you've noticed mental changes, please have this specific conversation with your urologist or primary care physician. Number 6, benzodiazepines. I want to take a moment here because this next category is one that evokes very strong feelings, and understandably so. Benzodiazepines, or benzos, have helped millions of people manage severe anxiety, panic attacks, and sleep disorders. For many, they genuinely felt like a lifeline during an incredibly difficult period. I am not dismissing that experience. What I'm asking you to do is hear the science. Benzos work by amplifying GABA, your brain's natural calming chemical. They're remarkably effective at producing short-term relief. The problem is what happens when that mechanism stays switched on for months or years at a time. A 2022 study tracking over 8,000 seniors across a 6-year period found that those who used benzodiazepines for more than 3 months had a 51% increased risk of developing Alzheimer's disease. The risk was highest with long-acting formulations like diazepam, which accumulate in fatty tissues, including brain tissue, over time. Here's the biological explanation. When GABA is chronically overstimulated, the brain begins scaling back its own natural activity in response. Neuroplasticity, the brain's ability to forge new connections, learn, and adapt, begins to break down. Memory formation slows. Emotional regulation falters. The brain that was being calmed loses its capacity for dynamic, flexible thinking. And the trap? When you try to stop, withdrawal can be brutal. The rebound anxiety and insomnia that follow are often far worse than the original symptoms, which makes the medication feel indispensable even as it's contributing to the problem. Important: never stop benzodiazepines abruptly. This can be medically dangerous. Work with a physician on a slow, closely supervised taper over weeks or months. Alternatives include buspirone for anxiety, cognitive behavioral therapy for insomnia, CBTI, for sleep issues, and in some cases, low-dose melatonin or magnesium glycinate. Number 5. Statins. Before I explain this one, I want to be careful, because statins genuinely do save lives. Cardiovascular disease remains the leading killer of people over 60, and for many patients, statins are both appropriate and necessary. But here's what your cardiologist may not have mentioned. Your brain is composed of nearly 60% fat. Cholesterol is not the villain it's been made out to be, at least not in the context of your brain. It's a structural requirement. It forms the myelin sheath, the insulating layer around your nerve fibers that allows signals to travel rapidly and efficiently. It plays a role in synapse formation. Without adequate cholesterol, your neurons struggle to communicate effectively. When you aggressively lower cholesterol throughout your entire body using a statin, you risk crossing a threshold where the brain simply doesn't have what it needs to maintain its architecture. The FDA actually updated statin labeling back in 2012 to include warnings about memory loss and confusion as potential side effects, a relatively rare step taken after reviewing thousands of adverse event reports submitted by patients. A 2023 analysis published in Frontiers in Aging Neuroscience found that adults over 70 who used high-dose statins for more than 3 consecutive years showed a measurable increase in mild cognitive impairment compared to non-users. Here's an important distinction. Not all statins carry the same cognitive risk. Lipophilic statins like simvastatin and atorvastatin cross the blood-brain barrier more readily. Hydrophilic statins like pravastatin and rosuvastatin have shown significantly less cognitive impact in comparative research. If you're on a statin and experiencing brain fog or memory changes, ask your doctor whether switching to a hydrophilic statin might offer you the same cardiovascular protection with fewer cognitive effects. Also ask to have your CoQ10 levels checked. Statins deplete this compound, which is critical for cellular energy production in the brain. If this has been valuable so far, consider passing it along to someone you know who takes statins. This is information most people simply don't have access to, and a simple like on this video helps it reach more people who need to hear it. Number 4. Amitriptyline. This one catches people completely off guard every time, because amitriptyline is frequently prescribed for conditions that seem entirely unrelated to psychiatry. Nerve pain, chronic migraine prevention, fibromyalgia, even insomnia. It's an older tricyclic antidepressant that's been repurposed over the decades for a wide range of conditions. Physicians sometimes choose it precisely because it induces sedation, using that side effect intentionally to help patients sleep. But here's what makes amitriptyline uniquely hazardous for aging brains. It is among the most potently anticholinergic medications still in widespread clinical use. Its binding affinity for the muscarinic receptors, the sites where acetylcholine carries out its work, is extremely high. Higher, in fact, than many drugs that were specifically engineered as bladder medications or allergy treatments. A landmark 2015 study published in JAMA Internal Medicine followed more than 3,400 adults aged 65 and older over a 10-year period and found that high cumulative anticholinergic exposure, with amitriptyline among the top contributing medications, was associated with a 54% greater risk of developing dementia. And the damage doesn't necessarily show up in a sudden, dramatic way. There's rarely a clear warning sign. Instead, there's a slow, creeping erosion, difficulty finding words, trouble with sequencing, a growing inability to hold complex thoughts together that gets attributed to normal aging for years before anyone thinks to look at the medication. Alternatives. For nerve pain, duloxetine, Cymbalta, or gabapentin carry far less anticholinergic burden. For sleep, low-dose doxepin in very small amounts has a more favorable receptor profile. For mood, modern SSRIs like sertraline are significantly safer for aging brains. Number 3. Antipsychotics. Pay close attention to this one, because what I'm about to describe happens every single day in nursing homes, memory care units, and hospitals across this country, and most families never find out. Antipsychotic medications were developed to treat serious psychiatric conditions: schizophrenia, bipolar disorder with psychotic features. They are powerful, brain-altering drugs with a significant side effect burden. Yet today, they are routinely prescribed off-label to elderly patients who are simply confused, restless, agitated, or difficult to manage, not because they are experiencing psychosis, but because they are inconvenient. I'll say that again. There are seniors in long-term care facilities right now who are being chemically sedated with antipsychotic medications, not for their own benefit, but for the convenience of understaffed caregiving environments. The FDA issued a black box warning about this practice over a decade ago, citing a significantly increased risk of death in elderly patients with dementia-related behavioral symptoms. And yet the prescriptions continue. Here's the neurological damage. Antipsychotics work primarily by suppressing dopamine, the brain chemical tied to motivation, reward, movement, and executive function. When dopamine is chronically suppressed in an aging brain, the results include emotional blunting, slowed cognition, impaired memory consolidation, and accelerated neurodegeneration. A 2022 study published in The Lancet Healthy Longevity, tracking more than 25,000 older adults, found that seniors prescribed antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even among those with no prior dementia diagnosis. If you have a loved one in a care facility, or if you yourself are being prescribed quetiapine or risperidone for reasons other than documented psychosis, ask direct questions. Ask why. Ask what the plan is to eventually discontinue it. Ask what non-pharmaceutical behavioral interventions have been explored first. You are entitled to those answers. Number 2, paroxetine. This one doesn't get nearly enough attention, and it genuinely deserves far more. Paroxetine, sold under the brand name Paxil, is classified as an SSRI, a selective serotonin reuptake inhibitor, the same family as Prozac, Zoloft, and Lexapro. And when most people hear SSRI, they think safer antidepressant, modern, better tolerated than the older drugs. That's accurate for most SSRIs. Paroxetine is the exception. Unlike every other SSRI, paroxetine carries significant anticholinergic activity. That single pharmacological quirk sets it completely apart from its counterparts. While Zoloft and Lexapro leave acetylcholine largely undisturbed, Paxil interferes with it in a way that much more closely resembles the older tricyclic antidepressants than it does its fellow SSRIs. A comprehensive 2021 review published in Frontiers in Psychiatry found that elderly patients on paroxetine showed measurable declines in short-term memory and verbal recall within the first year of treatment, declines that were not observed in patients on other SSRIs at comparable doses. The American Geriatric Society has placed paroxetine on their Beers criteria, an official list of medications considered potentially inappropriate for older adults, specifically because of this cognitive concern. What's particularly frustrating is that paroxetine is often prescribed to older adults for anxiety and depression, the very population for whom it poses the greatest risk. The solution is straightforward. If you're on Paxil and you're over 60, ask your physician whether transitioning to sertraline, Zoloft, escitalopram, Lexapro, or another SSRI might provide equivalent antidepressant benefit without the anticholinergic cognitive burden. Most patients make the transition successfully with careful, gradual tapering. Number 1, anticholinergic polypharmacy. We've arrived at number 1, and as I promised at the beginning of this video, it isn't a single medication. Let me explain precisely why, because I believe this is the single most important thing I will say in this entire video. Every drug on this list, taken in isolation, might produce only mild, barely perceptible cognitive effects in certain individuals. A bit more mental fog, a touch more forgetfulness, easy to overlook, easy to attribute to getting older. But here's what actually happens in the real world. Seniors don't take one medication. The average American over 65 takes 4 or more prescription drugs daily. Many take 6, 8, 10 or more, a combination of prescriptions, over-the-counter products, and supplements, often written by multiple different physicians who may have limited visibility into each other's treatment plans. When several of those medications carry anticholinergic properties, they don't simply add to one another's effect. Research suggests they can multiply it. A 2022 analysis published in Age and Aging tracked over 280,000 older adults and found that those with the highest anticholinergic burden, measured using a validated tool called the Anticholinergic Cognitive Burden (ACB) scale, faced a 120% increased risk of developing dementia over a 10-year period, double the normal risk, from pills that most of them had never once been cautioned about in terms of brain health. Let me illustrate what this looks like in practice. Picture a 70-year-old woman, let's call her Dorothy. She takes Benadryl PM every night to help her sleep. She takes oxybutynin for her bladder. She was recently prescribed amitriptyline for nerve pain in her feet. And she takes an over-the-counter heartburn tablet every morning. 3 out of those 4 medications are anticholinergic. Each one, according to the separate doctors who prescribed them, is appropriate and safe on its own. Together, her cumulative anticholinergic burden score may fall within a range clinically associated with serious dementia risk. And not a single physician, not a single pharmacist, has ever done that calculation on her behalf. This isn't hypothetical. This is Dorothy. This is Margaret. This is your neighbor, your mother, your partner. The medical term for this is polypharmacy, specifically anticholinergic polypharmacy, and it may be the single most underreported driver of dementia-like symptoms in the elderly population today. Now here is what I need you to hear, and I need you to hear it clearly. Drug-induced cognitive decline is often reversible. I have witnessed it personally. When the medication burden is properly identified and systematically reduced under appropriate medical supervision, many patients experience a remarkable restoration of mental clarity. Memory comes back, personality reemerges, the fog lifts. Your brain is not a passive, fixed organ. It is adaptive, resilient, and fully capable of healing when given the right conditions to do so. Your 5-step action plan, start this week. Step 1. Write down every single thing you take. Prescription medications, over-the-counter products, supplements, sleep aids, everything. Don't leave out the PM pain reliever you use occasionally or the allergy pill you've been taking for years without thinking twice. Step 2. Look up each item on the Anticholinergic Cognitive Burden (ACB) scale. This is a free, publicly available tool that assigns a cognitive risk score to medications based on their anticholinergic properties. A quick search will bring it right up. Step 3. Schedule a dedicated medication review with your primary care physician. Use those exact words. I'd like to schedule a medication review to assess my anticholinergic burden. A good physician won't be offended. They'll appreciate that you're advocating for yourself. Step 4. Ask specifically about deprescribing, the intentional, supervised process of tapering off medications that are no longer necessary or that carry unacceptable risk. It is a legitimate and rapidly growing field within geriatric medicine. Step 5. If your physician brushes off your concerns, seek a second opinion. You are not being difficult, you are being responsible. A geriatric pharmacist, yes, that specialization exists, can also conduct a thorough, comprehensive medication review. Before you go, I want to hear from you. Which of these 9 medications are you or someone you love currently taking? Have you experienced any of these symptoms? Brain fog, memory lapses, personality shifts, confusion, and never once connected them to a medication? Have you ever had a doctor dismiss your concerns about cognitive side effects? Share it in the comments. I read them. This community reads them. And sometimes the most valuable thing is simply knowing you are not alone, and that what is happening to your mind is not inevitable. If this video helped you today, please pass it along. Send it to a family member. Share it in a group. The person who needs it most probably isn't going to stumble across it on their own. You could be the reason they find it. I'm Dr. Eric Sanat. Thank you for investing this time with me today. Your brain is worth protecting, and now you have the tools to start. Stay sharp, stay informed, and I'll see you in the next one.